to today's talk. We've got the wonderful Ciarán Driscoll from UCL. Ciarán is an associate professor of clinical psychology and co-director of the core data lab, and specializing in mental health data analytics, particularly in understanding how symptoms evolve and develop together, and is going to be talking to us about some really interesting work he's been doing with secondary care data. Ciarán, the floor is yours. Thanks so much for being here.
Yes, hi all. Yeah, my name's Ciarán Driscoll. As I say, I'm an associate professor at UCL. I'm also a clinical psychologist, and I think today can very much be thinking about being a clinical academic. And the focus will be on healthcare equity and severe mental illness and how we can use data science to address that. And so for following my training for a number of years, I worked solely in clinical practice in the NHS, in early intervention and psychosis services. And within that role, I was kind of doing research related to my clinical work, issues that I noticed, which gave rise to research questions. So more of a clinician there with with a clinical research perspective rather than a pure research perspective. And so today the talk will think about how important data science is in tackling questions in serious mental illness services, the barriers that we face, how tricky it can be, and what you can do to improve it. So do want to temper expectations, because I know there'll be people from lots of different places, and do feel free to bow out now and have your lunch if it doesn't seem like it's going to fit. I think it's going to be a broad overview, giving a bit of an introduction to things, so don't expect a deep scrutiny of more an introduction, and definitely don't expect to be able to do any of these things at the end. So the theme of these talks is around health equity, and this is the guiding star here. With data science, we can sometimes get a little bit seduced or drawn in by an approach and then try and make it fit the question. But as we know, the research question should lead the way. And now when we say health equity, what we're really talking about is making sure everyone has a fair shot at being as healthy as they can be. And when this comes to SMI, it's not a level playing field. And I see this as tackling three main areas where we might see unfair differences. So looking at access, can people actually get the healthcare they need? Quality, is everyone getting the same standard of care? And then examining outcomes. Are different groups of people ending up with different results from the healthcare that they actually receive? And by letting questions like this guide us, rather than starting with a particular research methods, we're more likely to find meaningful answers that can help us create positive change. And when we're thinking about severe mental illness in the UK, the scale of the issue is significant. So we're seeing about 1 in 50 adults in the UK living with severe mental illness, disorders like schizophrenia and bipolar. And what's particularly concerning about SMI individuals is that having an SMI, individuals typically live 15 to 20 years less than the general population. So there's the disparity there in the care that they're receiving, or something in relation to living with these disorders. And we're seeing some troubling patterns in how care is delivered. So we're seeing people from lower income backgrounds, rural areas, and ethnic minority communities often facing greater barriers to accessing appropriate care. And when they do get the care, the outcomes aren't always equitable. And at the system, I'm going to talk about the system, talk about the NHS here in terms of what I talk about today. It faces several operational challenges. As we know, there's issues around staffing and resources. There's long waiting times. There's rather fragmented care pathways in terms of how people eventually get the care they need, and people can't fall in between the gaps. And then there's engagement issues as well, due to people experiencing stigma, and in cases where people have had lots of negative past experiences. The NHS has launched several major initiatives to try and address this, including the long-term plan. And we're there's consultation out at the moment on the next 10-year plan, so we'll wait to see what's going to be focused on there. And these kind of specifically ring fence mental health funding to help address these issues. And the goal is kind of clear. The aim there is to achieve a true parity between mental and physical health services. But I'm sure, as you're all aware, there's quite some way to go there. And with developing and gaining access to large data sets in the healthcare sector, data science can help us to unlock its potential. And what's exciting about this is how we use this information in ways that directly benefit both patients and the NHS. And this can help us to make real world differences and change services. We can think about tracking recovery patterns across different treatments to understand what works best for whom. We can use things like predictive modeling to reduce missed appointments and to save time and resources for everyone involved. And these approaches can help us make more informed decisions as well around patient care. So using clinical outcome data to guide treatment choices, or understanding what medication strategies work best for different conditions, things like treatment-resistant depression. And so there's a lot of potential here for data science to transform healthcare delivery and improve patient outcomes, and improving patient outcomes will go well beyond this. So I think there's great utility in kind of understanding and knowing about data science and the intersection there between kind of being a researcher and being a clinician and what you can actually achieve. So obviously one of the first questions in any data science project is like, where can I get the data? And in this, we do have quite a few options available to us. So there's a number of research groups across the country and universities that have been compiling data sets and most importantly, kind of cleaning them, but also kind of linking them. So linking across GP data to hospital data to mental health service data. And then at the national level, there's lots of resources. There's the NHS Digital Mental Health Data Hub, which is a goldmine of information. There's a UK Biobank, which has extensive mental health data within it. And then something which is kind of there, but like you can't actually access it at the moment, is Open Safely, which looks like a really powerful platform for analysis of electronic health records data. And they're not currently accepting studies. They have had some which they've trialed, but the aim here is that actually they'll have done all the kind of linkage in the background between the data sets, and you can write up your code, they will run it, and you get the output back. But when we're thinking about this too, don't overlook what's available locally. So if you're a clinician, what you might have within your department, or if you're a researcher and you're not finding it there, making the links there with secondary care services, because there might be other ways that these things are recorded. So in some cases, the trusted electronic patient record systems might be linked to some of these larger data sets, but others they won't. And from a clinical level, you can kind of get access to the data within the electronic patient record systems data. And then beyond that, there's also departmental data sets as well, which are tracking various metrics and outcomes, which are particularly important for that department. And if you find you don't have the data you need, the suggestion would be to start collecting it. And sometimes the best projects begin with setting up a good data collection process. You get to kind of choose what exactly it is you want to kind of to look at. But obviously, there's kind of setup things and time issues that come with this. And then with the data sets that are available, like a question is, I have big data, but can it help me answer my health equity questions? And here we do hit a bit of a hurdle, well, actually quite a large hurdle, the missing data. And it's missing in some cases at a level that can render it difficult, if not impossible, to use at times. So here's a study which was looking at the Chris Oxford data set. And they had 158,000 patients, so many patients. But we can see here, if you look down the list, if you want to look at religion, you've only 20%, alcohol, 10%, sexuality, 5%. And the question here is like, why? Why is this missing? And it might be that clinicians don't ask the questions, or they don't fill it out because they don't have to, or maybe these are questions that are difficult to ask particular people with certain diagnosis or certain groups, which means that, even if you use the data that's there, you can't really infer much, if anything, because the data isn't missing randomly. There's kind of reasons why it's missing. And then we can see there, though, that like something like ethnicity is kind of collected quite well. But even that can kind of present a challenge, because actually it's actually recorded extremely well there in terms of their in some data sets, it's just linked to kind of like the 5 ONS categories. But within secondary care, it's extremely open, even for kind of people to kind of input exactly how they kind of identify it themselves. But this presents other problems than in grouping, because if you kind of look at that, even with a large data sets like this, you can end up having extremely small samples, which you then end up having to kind of just group people together. But I don't want to kind of overly kind of despondent. Some data sets are better than others, and it won't always be the case across data sets. And as I'll get onto it, there might be some workarounds around this as well. But so as I say, research showing that much of the structured data from electronic health records isn't quite hitting the mark. And so there has to be a big call here to improve routine measurement. We can see in primary care, IAPT, really successful at doing this. But for whatever reason, especially with the structured data, clinicians in secondary care are less likely to do this. They're less likely to input the kind of standard data, and much, much less likely to complete any outcome data. So NHS England is taking steps to address this, and they are recommending some specific patient-reported outcome measures or PROMs, and the aims that these are to be implemented in community mental health by the end of this year. And these tools are brief. They shouldn't have much, shouldn't be that much burden there on the patient or the clinician, and they cover how satisfied people are with different aspects of their lives and their care. So how well people are meeting their goals for treatment, the quality of life and recovery. And I know something like the dialogue has been in use for a few years, and it seems that this has kind of been taken on quite well. It seems to be mandated. I'm not sure so much about the goal-based outcome tool or the qual measure. But a standardized approach to measurement of demographic and outcome variables would be amazing, and it would mean that we'd have consistent, meaningful data to work with across services. However, you can see in the other one, we do see the return on demographic data, and for most part that is mandated, and you can see that's sparse, so we'll just have to see what happens with the outcome data. So let's explore some ways in which data science is being applied in mental health care, and think about these as different tools in our toolbox, each with its own special purpose. So big data analysis is helping us to see the bigger picture, understanding how people use services, and also how social factors influence mental health. And it's giving us a bird's eye view of the entire system. So things like predictive analysis, we're getting better at anticipating needs. And so imagine being able to identify who might need extra support before they reach a crisis point. Machine learning, particularly fascinating, so helps us personalize treatment approaches. We're getting better at matching people with interventions most likely to help them. And natural language processing, or NLP, is opening up lots of new possibilities by helping us make sense of the rich information in clinical notes and patients' narratives. And this might help us to address these missing data problems. And these aren't just theoretical applications, these are making a real difference in many health care settings already. And one of the most powerful applications of data science is in addressing healthcare inequalities. And this isn't just about identifying problems, it's about creating solutions. So we can use the data as a spotlight to illuminate disparities which we might otherwise miss. And by analysing different patterns in treatment and outcomes across different demographics and regions, we can see exactly where the gaps are. And more importantly, then we can do something about them. So ideally, we're not just documenting inequalities, we're developing tools to prevent biases in clinical decisions, optimize resource allocation to areas where they need it most, creating targeted interventions for underserved communities. And this isn't a one and done exercise. This requires continuous monitoring, evaluating of equity initiatives, so we can keep improving and adapting our approaches to ensure everyone's getting the care that they need. So let me share a bit of an example here of data science in action. And this was a study, and it's now a tool called psychologist, which stands for psychiatric mapping, translated into innovations for care. And it's a fantastic tool that predicts the expected number of new cases of psychosis in different areas across England and Wales. So we can think about it as a forecasting system for mental health services. And what they're doing is they're combining population data, social factors, demographic information, and then identifying a model which kind of best predicted new cases. And so this tool can estimate how many people might need early intervention in psychosis services in any given area. And so this can help services plan ahead. If you know you're likely to see an increase in cases in certain areas, you can make sure you have the right resources in place. And so this is a really useful tool for commissioners and service managers in planning and developing mental health services. And it's a perfect example of how data science can translate into practical real-world benefits for both service providers and the people they support. And there's the kind of website, and you can go onto the site and play with it and look at the different regions. And it is a forecasting model to identify probable FEP, so those who are expected to need it, but they're also kind of clear within it on the areas where the model is not is going to be less accurate there, identifying, say, kind of people aged the over and underestimated probabilities there for the different age groups. So the next a few studies I'm going to go over are things that are kind of studies that I was doing when I was in clinical practice and kind of working my way with through the data, trying to answer these questions. And again, kind of answering questions that were kind of really relevant and pertinent to what was going on within the services at the time of the work that I was doing. And they do kind of concern the unequal service provision at the time based on different things. And they really do kind of call for more personalized kind of interventions to address different patient profiles. So this first study here, it's centered around EIP service, early intervention in psychosis services. And at the time, they had a traditional age cutoff of 35. And this cutoff seemed kind of was kind of arbitrary, but there was some sort of like clinical rationale for it. But what we wanted to do is have a look at the data and see if the data spoke to this too. So we kind of used the data set within the service. So we had like 343 clients, and we were able to get the data down from the electronic patient record system to have a look at this question. And what was really interesting, what the data showed us was really interesting. When we started looking at people experiencing the first episode of psychosis, their clinical and functional needs are remarkably similar, regardless of stage. And so when there were kind of differences in outcomes, they're actually more about social factors than clinical factors. When we're talking about social factors, it's just things in relation to just being an older person. So things like employment status and housing stability were having as much impact on outcomes as clinical factors. And so at this time, there was kind of a call for more age-inclusive services, and this was kind of providing the evidence that age-inclusive EIP might be more appropriate than using these cutoffs. And I think this kind of insights exactly what we need to build more equitable services. And I think the choice of analytic method was kind of important here. And so what we were using were these classification and regression trees. And what makes these special is that they're not just powerful, but they're also incredibly practical for a clinical setting. So the tree makes a series of yes/no decisions based on different variables, and it creates a pathway to prediction. And what's great about this is we can follow the logic. It's not a mysterious black box algorithm. And unlike some complex statistical methods that assume linear methods, these trees can handle the messy reality of healthcare data, where factors might interact in unexpected ways. And as I say, it's really important here how clinician friendly these were. It makes it much easier to integrate into clinical decision making and explain it to colleagues who might be skeptical of more complex statistical approaches. And I think this example here of a study, I think is much clearer than my own. And we can see how they use the results of the classification tree to inform clinical decision making. So it's a flow chart here that has looking at the risk assessment of perinatal episodes in women with bipolar who have already children. And you can just follow it down. And does the person have a history of mania, yes or no? And then thinking about looking at them having a previous bipolar episode, what the kind of likelihood of an occurrence would be. This next study then was a study that we did in conjunction with West London, where they had one of these large data sets called CRIS, where they've brought all the secondary care data together. And what we're kind of interested in here was that when you're in early intervention psychosis, you're there for 3 years, and we're very interested in like what was the journey like for patients, and does everybody have a similar journey? And if you don't have a similar journey, you know what's kind of going on. So looking at like assuming here that there are going to be disparities there across the 3 years. So this was a much larger data set. We had 2,363. And we had data from a number of different things. So we had their diagnosis, admission dates, gender, age, ethnicity, and in this case, first language, really. We had kind of enough data on those to be able to include it. And we also were able to use these ANOS subscales, which was because we wanted some sort of giving us some sort of clinical measure there. And these subscales they assess kind of behavior impairment, symptoms, and social functioning of the individuals as well. And so what we used was this model-based clustering to identify subgroups within the data set. And then we used latent growth models, tracking the group's journeys across the 3 years of EIP. Did they stay in EIP? Were they admitted to hospital? Did they go to a crisis team? That's the cat here. And then we looked at regression models to investigate certain kind of associations between the patient characteristics and the identified profiles. I'd say some of the challenges with this data set was kind of like certain things that variables we wanted to use, we weren't because of the missing data. And then particularly for this, where we wanted to know the type of service, is that actually within the data set, they had service names, which could be like the name of a building rather than necessarily the type. So it required a lot of local knowledge and kind of linking in there with people who knew about services and and what that would have been. So there's a lot of kind of manual editing there to kind of do in relation to that. But what we find anyway, the research identified 5 distinct profiles of how people use services. And I think the results raised some kind of interesting questions about equity in the system. Particularly noteworthy was certain ethnic groups, especially Black African, British African, and Asian British individuals, much more likely to be in profiles showing higher intensity care needs. So that in terms of kind of inpatient and crisis intervention. And we're also kind of seeing interesting gender patterns as well, with women more prevalent in certain service use profiles. So that a profile 1, a lot more female, but also getting a lot more of the crisis management, but not necessarily of inpatient. And so what's kind of powerful about these findings is that they help us move behind or beyond kind of anecdotal evidence to see kind of clear patterns. And they suggest, and I think in this case, we thought they suggested some systematic biases in how services are accessed and provided, particularly around pathways to care and clinical decision making. So I think that this kind of insight, these kind of insights that data science can provide can help us identify where we need to focus our efforts to create more equitable services. In this example, it's an example of service research where we did have to kind of create the data set from scratch. It was a care intervention in EIP service, requiring a lot of commitment from people involved to ensure data completion, but it formed part of the role in the team. And it was an intervention that was delivered by assistant psychologists for carers of people with first episode psychosis. And so what's notable about this is that on the outset, it's an evaluation of intervention, but we're also able to model some of the processes in therapy using network analysis. So we could see that people improved, but we wanted to see how the relationships between constructs changed. So So with this, we kind of knew that we know that the role of stigma in help seeking, and the relationships between people, between kind of carers and the individual with psychosis, can kind of result in what's kind of expressed emotion, which is associated with relapse. And so before the care intervention, we observed a strong connection between anxiety and stigma. And after, not only did both anxiety and stigma levels decrease, but interestingly, the relationship between them disappeared completely. So this kind of tells us something crucial about how the intervention worked. So we can kind of, what I suppose we can kind of infer here is that it likely provided caregivers with knowledge and coping strategies that simultaneously addressed both issues. So by helping caregivers better understand psychosis, the intervention might have reduced their fear and uncertainty, leading to lower anxiety. And at the same time, it challenged misconceptions about mental illness, directly targeting the stigma. So these insights into the mechanism of change wouldn't be visible with kind of traditional statistical methods, just using the t-tests. These Gaussian graphical models or network models help us see a bigger picture of how interventions create change through multiple interconnected pathways. So, as I kind of mentioned earlier, data can be poor in secondary mental health care data sets. But actually what we do have a lot of data on is in the unstructured, it's in the notes. And like clinicians always complain about having to do notes, but they do seem to like writing notes a lot. But with this wealth of kind of unstructured text data, there is an opportunity there, but there's also a challenge. And this is where natural language processing, or NLP, comes in. With NLP, it's just essentially teaching computers to understand and analyze human language. And we can use NLP to help mine these clinical notes for crucial information. And this can be tracking symptoms, treatment progress, to identifying early warning signs of deterioration. And in services, sometimes you'll, like people, when they're kind of reviewing stuff, they'll have to go in and manually review all the clinical notes. And sometimes we'll have students here who will be doing that in order to get it. And this offers another way of doing it. So, a clinician could be reading through years of notes to try and understand a patient's journey, whereas an NLP can do this in seconds, highlighting key patterns and concerns. So we have some practical applications, a couple of studies there, analysing NHS patient feedback to improve services and enhance risk assessment, with clear implications here. If we can get this to a high standard for clinicians, this would mean less time reviewing paperwork and potentially more objective insights to support their clinical judgment. However, we'll say, do need to be mindful of challenges here, protecting patient privacy, addressing potential biases in these systems, and ensuring these tools actually fit into clinical workflows rather than just adding to them. So the goal isn't to replace clinical judgment, to enhance it with some data-driven insights. So as I'm saying, kind of most valuable clinical information isn't neatly organized in checkboxes or drop-down menus. It's going to be buried in the free text notes. And so while these NLP could be a solution, developing them requires a lot of work. So it requires creating what's called a support vector machine language model, and this isn't simple. It needs extensive human annotated training data to serve as a gold standard. So the Jackson 2016 study here, for example, it required annotating over 32,000 documents to track just 50 symptoms. And the key is having enough diverse features for this model to accurately distinguish relevant from irrelevant information. And this is going to be difficult even for something like symptoms, where in terms of how people actually describe symptoms, maybe using terms like motivation or mood, which people use in various contexts, and it's going to make them less reliable. But like they can be used, and then these efforts can kind of pay off. So in the Irving 2021 paper, their research showed that by incorporating NLP extracted symptoms into a psychosis risk calculator, that they could significantly improve prognostic accuracy. And on top of that, when someone kind of creates this model, these models are kind of available, and there are many validated models available for clinical researchers to use. And I know within kind of if you're kind of using Chris, there will be some of these models that you can use without having to kind of create your own. So this is a plot from the Jackson paper. And so they're plotting, they plot a bar chart of the counts of unique patients exhibiting each symptom. And they're colored there by the diagnosis and the symptom domains, respectively. And so in the SMI cohort, the counts of patients exhibiting the very symptoms and the prevalence of each symptom ranges from common there on the left of paranoia, so about 59%, to the very rare catalepsy, which was like less than 1%. However, a major limitation was that they could only identify at least one symptom in 87% of the SMI patients. So the symptom detection wasn't great. And this was in partly due to their symptom list, where they didn't search for certain symptoms. Or more importantly, in terms of clinical notes, they didn't include more colloquial terms. So when they were looking for auditory hallucinations, they didn't also include hearing voices. And their rationale was that it risked introducing ambiguity about clinical meaning, which is probably right, but it makes large assumptions about how people write notes and the different people writing notes and how they're going to describe things. So, like I just don't know who's writing catalepsy and who might write about a person's body becoming stiff and they can't move for a short period of time. So this brings us to large language models. And these offer several advantages over traditional NLP models when it comes to extracting details from clinical notes. So they have a broader knowledge base. LLMs are trained on massive data sets, allowing them to grasp a wider range of medical concepts, terminology, and nuances compared to NLP models, which are trained on more specific data sets. They excel at processing natural language. So they're able to kind of process complex medical jargon and also the ambiguous language, with the hope that this could lead to more accurate identification of relevant information. And they can better understand the context of clinical notes, considering patients' history, current systems, and overall narrative, which is kind of really important for accurate information extraction. And they can be trained as well to kind of improve the precision in relation to what you're looking for. So here we just kind of have just thinking about what you kind of put into it. So these are just different kind of strategies of training them. And I think the thing here is just that you have your kind of zero shot, which is no examples. It's just your LLMs if you're kind of putting into ChatGPT. And then you can there's kind of additional layers of training or complication in terms of providing more training data or examples, or actually creating like a bit of a logic there for them to kind of search through the data. So there's this is kind of early days for this, and there's this study which is a preprint where they looked at extracting social determinants and family history from clinical notes. And in this study, they reviewed 1,000 notes from 150 patients. And so they're kind of using a zero-shot learning method. So they're using GPT, so they're using OpenAI's GPT 3.5 method. They're not going to train it on anything. They're just kind of putting in the data and seeing how it does. And they're looking at like precision, this F1, which is the average of the precision and recall. So they're looking at how many of the positive predictions made were actually correct, and giving it a score. So we can see here is that it's no training. It's really accurate at age and gender, which, you know, you could think that's not that difficult, but then less so on the social determinants. And these are things like employment status, alcohol use, tobacco use, drug use, and also on family history. So things like vital signs and clinical observations. So it's not that accurate, but actually kind of more worryingly is it's not stable. So they're not getting the same results each time. And even more concerning, it's making things up. So it's coming up with kind of results that weren't there. And the most concerning thing is that you can't cross-check this. So you got your input, you got this hidden stuff that's going on in the middle, and then you're getting your output. But this was like a zero-shot approach. You know, these things are under development. They require very careful validation and testing before adoption. And I would imagine that, like, you know, this will be the future. So what it's saying here is that when we're identifying kind of disparities in secondary mental health care, we do need to take a comprehensive data-driven approach. Like demographic analysis is crucial. You know, we need to examine factors like age, gender, ethnicity, socioeconomic status, not just individually though, but through like an intersectional lens. So, you know, so using multi-level analysis to model these inequalities, defined by like the intersection between multiple social and demographic dimensions. And this will just provide a better understanding of health heterogeneity existing in the population. So we're not just talking about people within an age group or certain ethnicities, that we're able to like look at the intersection between all of those to find kind of discrete subgroups that might be experiencing elevated inequality in terms of health provision. So give an example there of MEDA, which stands for Multi-Level Analysis of Individual Heterogeneity and Discriminatory Accuracy, which is a statistical modeling approach to do that, to be able to model the intersectionality. And this approach can help us to understand how these factors interact and overlap to affect mental health outcomes. So we looked at with the earlier, we can map access to care across different regions. And this is going to use a geospatial analysis to understand where services are located and who can reach them. And I think this is like a critical modern consideration when we're thinking about the digital divide. Not everyone has equal access to telehealth or digital health services. And there's such a drive in that area that lots of people are going to get left behind. We can track specific metrics to reveal systematic inequalities as well. So things like waiting times for appointments, rates of involuntary admissions among different demographic groups, variations in prescription patterns, how different populations engage with psychological interventions. And by analysing these elements together, we can identify where the disparities exist and develop strategies to address them, working towards a more equitable mental health care for all. Do need to think about the ethics with these data science approaches, especially when we're pulling on some of these more advanced like AI approaches, and particularly where we might not be able to kind of understand exactly what they're doing or how they're reaching certain conclusions. So we need regular testing to ensure the algorithms don't inadvertently discriminate against certain groups. And so this would mean requiring a lot of disparate impact analysis across different populations. And healthcare professionals and clinicians need to understand how and why different analytic approaches make their decisions. You know, we can't have the black box algorithms making these healthcare choices without transparency. And we do want these tools to enhance rather than replace us. And we need to kind of strike the right balance there between what's kind of automated and what's the human element. And so, this is thinking about training clinicians to effectively use data science insights. They don't necessarily need to understand everything, but to be able to kind of use them while maintaining their kind of day-to-day meaningful interactions. And most importantly, we need to just remember that actually underserved populations might not be well represented in these data sets. So you might not be able to kind of identify them. And that whatever algorithm design you're using, it needs to account for these groups to ensure equitable healthcare delivery. Oh yeah, and then just the NHS, and finally, just with any kind of development, just adhering to established ethical guidelines, and there's those there from the NHS-AI lab to ensure prioritize patient welfare. So there's a myriad of ways we can work to address inequalities using data science, but as we do kind of move ahead with solutions, we need to think about how they'll be used, who benefits, and who will be left behind. So final slide, or well, second to final slide. So, as I'm saying, these things can be useful if they're done thoughtfully. And the key is just to finding the right balance between our clinical expertise and data insights. And depending on your background, just collaborate with people who fill the gaps. Don't kind of be approaching just on one side. So clinicians start by integrating data analysis into your daily practice, while maintaining that kind of human element of care. And so this means using evidence-based insights to enhance rather than replace your judgment. And if you're a clinician, connect with data scientists and researchers. They need your clinical expertise as much as you need their analytic skills. If you're an academic, do develop an understanding of the clinical reality from which this data has emerged, not just about like the services themselves, which is how these notes are created. Actually getting involved in this is easier than you might think. Don't be intimidated by data literacy. Focus on understanding the basic statistical concepts, how to interpret visualizations. You don't need to become a data scientist, but if you know the fundamentals, it'll help you make better informed decisions. And just be an advocate. Advocate for better data infrastructures in your organization. Push for improved systems and tools to make data collection and analysis more efficient and easier to do. And even more importantly, involve patients and service users in this journey. Help them understand how their data contributes to better healthcare outcomes and implement tools for patient-reported outcomes. A lot of the time, the way that outcome measures are used, it's not always conveyed to the patient why they might be completing certain things. And remember, good data starts with good data collection practices. And so regular auditing, standardizing protocols are essential for maintaining data quality. So to wrap up, just want to emphasize the potential for data science in secondary mental health care, and that this is really important for addressing healthcare inequalities. And there's lots of tools here, and the NHS is uniquely positioned to implement these solutions. And the potential impact is significant. We can identify and intervene earlier, deliver better treatments, more personalized, reduce disparities that have long plagued secondary mental health care. And these approaches can just help us to be more efficient. We're always going to have limited resources, and we just need to kind of improve our efficiencies. But the future is not going to realize itself. We will need better data. Thank you.